I would like to introduce the next speaker, who is Dr. Lorenzo Padrone, who is an Italian colleague, an excellent colleague of mine at Norfolk Park Hospital. He's what we call a hybrid surgeon, being a vascular surgeon and interventional radiologist. And he's not just liked by all of the surgical team members, but he's also extremely helpful to our emergency surgical team with his great interventional skills. Lorenzo, thank you very much for speaking about the interventional radiology for abdominal emergencies.
Thank you very much, Joseph. It's a big pleasure for me to be here, surrounded by surgeons. So, this is the title that you gave me today, Interventional Radiology for Abdominal Emergencies. And, you know, the more we go forward, the more we're used to move to a virtual setting. So essentially, who's behind the mask of an interventional radiologist? And I would like to touch on this. So is he a surgeon, or is he a radiologist who is, you know, in some way takes some instruments in his hands? So, and I would like to ask you this question as Jesus asked to the 12s. And you, who do you say I am? So essentially, I consider myself a little bit like a plumber. And essentially, what I'm always asked is to stop the leak or to drain what's clogged. And so I will start this presentation with Stop the Leak. And I will start with a very controversial, of course, topic. It's the abdominal aorta. The abdominal aorta, you can see there are some sort of old dinosaurs, as we can call them. They are very much for an open repair, and also some young cowboys, as they are seen from the counterpart, who wants to stent everything in abdominal aorta. So some data, it's not very much clear what's best, but you know, for example, this is a very recent paper which was published in Journal of Vascular Surgery August last year, and it shows that EVAR does better in terms of mortality, length of stay, major adverse event, and 1 year survival compared to open. And you know, it's a pleasure to have Professor Davis here today moderating the session. He's part of the Imperial, and the IMPROVE trial came exactly from Imperial. And it says that more or less there are not huge differences, but still let's say what is suggested, patients, especially women with a ruptured abdominal aortic aneurysm, should be treated by EVAR if possible. And it's still a matter of debate. So let's go to something more straightforward, which is the bowel. And the bowel, you know, we can embolize the bleeding with different agents. Can be fibrin sponge, platinum coil, vascular plugs, embospheres, polyvinyl alcohol, and also glue. Exactly, the ATAC, the chanacrylate. And essentially, if you look at the American College of Gastroenterology guidelines, which came out a few years ago, you can see that conventional angiography should be performed emergently for hemodynamically unstable patients. And in the meantime, multiphasic CT can be performed to identify the site of bleeding and guide further management. Essentially, it's very important that also conventional angiography should not be performed as a diagnostic test in patients with overt bleeding. And it's very important to have a CT to understand. Of course, the patient is not always that relaxed, especially in case of bleedings. Essentially, you can see here 2 cases of bleeding where the patient, of course, was unstable. It's not always easy, but it's very important to get a CT to start planning what needs to be done. And you can see, for example, this patient with a 51-year-old in the bowel, the bleeding, and you can see the pre-contrast CT and the contrast CT in the portal venous phase. You can notice very well the little spot of white contrast inside the bowel loop at that level. You can see the angiogram, and if you want to look more in particular to the center, the lower part, this kind of small image that I will make bigger for you, and this is like as angiodysplastic lesions. And this kind of lesion can be very annoying, can be bleeding for a long time also, and can put the patient at risk. So after embolization with glue, the chanacrylate, the ATAC, you know, the patient was completely stable. If you look instead at the lower gastrointestinal bleeding, these are the last guidelines came out in 2019, and you can see that for a lot of patients, like who are, of course, unstable, the CT angiogram plus the treatment with, of course, embolization or endoscopically are still very much used. And you can see here, for example, a case where there was a bleeding from the inferior mesenteric artery. You can see how the first angiogram was performed at the level of the aorta, then to allow me to catheterize the inferior mesenteric artery. You can see here there's a blush. And this is the blush, which is, despite it's small, caused a big bleeding. The patient was unstable. And you can see here in the bigger picture how this was the vessel which was the cause of the small bleeding. After the colon embolization of this branch, of course, you don't have any more bleeding, and the patient was stable again. What's very impressive that when you embolize these patients, the patient starts having better blood pressure almost straight away. When we want to talk about, of course, upper GI bleed, we don't have to forget the gastroduodenal artery. Of course, this is always the territory of endoscopy, but just in this case, like you see, all the glue that was used from endoscopists was not still containing the bleed. And you can see here that you can't see a bleeding even in angiography, even with the supra-selective catheterization. But still, it's a good indication to embolize the gastroduodenal artery anyway, because of the failed endoscopical management. You can see how with our catheters, you can make different curves and arrive just at the level of the branches which are feeding the duodenum. And after the embolization, you can see how the small coils are going towards the glue, and the other coils are embolizing the main body of the gastroduodenal artery. What's very important is also having a run from the back door to check if the superior mesenteric artery is providing any source of back bleeding into that place. And it's also very important to see also if still the pancreatic arcade is still patent and the patient is viable with no further risk for surgery for pancreas necrosis. You can see here that it's not only about the bowel, it's also about the spleen. The spleen, of course, we have two scenarios, the unstable and the stable. Of course, the unstable usually goes to an emergency laparotomy, so it needs to be removed quickly and the splenic artery clamped as fast as possible. And always remember there could be a brain injury. Usually these are car accidents or big traumas. But if the patient is stable, it definitely needs to go to emergency CT. And then, of course, we need to evaluate on the CT and clinically the patient and see how bad is the injury, and you can go for conservative management if, of course, there's no source of bleeding and the patient is relatively stable, as we said, and of course you can go for embolization with on-call IR. If you look at the guidelines which came out in 2017 from the World Society of Emergency Surgery, you can see how there are loads of patients, of course the one which are not, as I said, completely unstable, which can benefit from angiogram plus or minus embolization. You can see, for example, the AST 4 and 5 grades. So essentially, even when the spleen is shattered, can be very helpful. And you can see that a vascular injury sometimes can be a pseudoaneurysm of an AV fistula. And this is very typical when you have a decrease in attenuation of delay phase. So you can see the pseudoaneurysm very well in the arterial phase, but then there's a low attenuation into the delayed portal venous phase. Or if not, there could be an active bleeding when there's an increase inside of attenuation on delayed phase, because of course there's more blood which comes out and of course causing more bleeding. Of course, it can be used also when a conservative management doesn't really help, and this is the case, of course, then when we sometimes need to rush things a little bit more than to leave the patient bleeding till reaching, 50 of hemoglobin. The embolization needs to be proximal, distal, or combined. Actually, we don't really know. Essentially, the guidelines are not telling us really straight what to do, especially in case of single vascular injury. Of course, there could be different approaches. So there could be the proximal or distal or a combination of the two. What I think is very important, my tips and tricks are to recognize the angiogram, on the angiogram, the dorsal pancreatic and greater pancreatic arcades and arteries, and avoid their embolization and avoid gel-full particles, just to try to avoid necrotizing pancreatitis. Of course, the spleen, despite if it's embolized, just to say also especially for medical students, is the vascularization of the spleen is provided by the short gastric arteries. But what about if there are multiple vascular injuries or severe? Essentially, I think the best is the proximal and distal embolization combination. So you can see here this spleen, which is completely shattered. You can see on the CT in the middle, and you can see here on the angiogram, like there are multiple sources of bleedings. So essentially, in this case, I think that the best solution is to perform a distal embolization to stop acutely the bleeding, and then to perform also an embolization more proximally to stop completely the blood flow there, because as we're seeing is a shattered spleen. Not only the spleen, it's also the kidney, which sometimes can be involved in traumas and bleeding. And you can see again, there are different stages of bleeding, and most of them, apart from when the pedunculus, the vascular pedunculus is completely detached, embolization, interventional radiology can help a lot. For example, this is quite a massive bleeding, grade 3. You can see how the kidney is surrounded even outside from its capsula from the blood, and you can see here on the angiogram that it's not that visible because it's a small point of contract extravasation, but it is very important to treat these because despite small, the kidney is very much irradiated. It can cause massive bleeding. So essentially you can see here with coils embolization how you can't see anymore the blush of contrast and the patient becomes stable. Of course, it's not just about the bleeding, it's also about the laceration, as in this case after trauma car crash, and you can see how the artery on the angiogram is all very much damaged, and you can see here when you inject into the vessel, you can see even more better, and you can position a stent and save the kidney, which was at risk. Not the kidney only, not the spleen only, also the liver. The liver, you can see these guidelines are very recent. They came out last year, always from the World Society of Emergency Surgery. You can see also there are different grades of liver trauma, liver damage, and you can see that the classification is very accurate, but I would like also to divide in two big groups: the intraparenchymal, where the bleeding is in some way surrounded by tissue which tamponates, and the extraparenchymal, which are the very urgent ones because the patient is bleeding outside from the liver. Essentially, in this very complex flow chart, I want to show you how easy it is to get to angiogram embolization. Say minor, moderate, or even severe lesion with a patient with hemodynamically stable, and if there's of course a positive blush at the level of the CT, of course you go for an embolization. It can be effective, and then you just need to check on the patient, or even if it's ineffective, you can reconsider an angiogram and before bringing the patient to operating room. So essentially you need to think not just once but twice about more conservative management with endovascular embolization. This is a typical case. You can see here the big bleeding at the level of the hepatic artery, which was fixed with a plug, which is a small, of course, a cork made of nitinol, and actually the patient was completely stable at the check and saved from the bleeding. This is something that you should remember from a very famous movie, which was Shining, and when the bleeding is more evident, it's always about esophageal varices. You can see here two cases where the esophageal varices are very, very prominent, and the interventional radiologist can help you with the TIPS, which is a transjugular intrahepatic postsystemic shunt. And you can see here in this very good document with indications like acute variceal bleeding that cannot be controlled endoscopically and rebleeding within 5 days is always been the main indication for TIPS, but it's also stressed in this document like early TIPS, within the 24 hours, is suggested in patients with relatively high risk of treatment failure, combined, of course, with endoscopic and pharmacological therapy. These are the best results for the patients. And the TIPS, how it happens, you go through the suprahepatic vein, and this is the most difficult part. You puncture into the portal vein, and once you have punctured in the portal vein, always be very sure to be intraparenchymal if you don't want to cause a massive bleeding. Then you check where you are, and you dilate the tract, and you position a stent to shunt the hypertension, which is in the portal vein, into the suprahepatic vein. This is a typical venogram, of course, with the injection into the suprahepatic vein and into the portal vein. You can see all the varices going towards the stomach and esophagus, and after having passed the wire there, you can deploy a stent and completely shunt the flow into the cava. You can see how the difference on the angiogram before and after. You can't see the varices anymore. We were talking about stopping the leak. Now we're going to talk briefly about drain what's clogged. Essentially, there's a mesenteric ischemia, and this is a big chapter which I'm very happy to present. Of course, the surgeons will look at me and say, what are you talking about? Mesenteric ischemia is surgical, especially when there's a bowel ischemia and bowel necrosis. Of course, but the approach can be also combined. And I want to stress this concept with this very recent paper, Contemporary Management of Acute Mesenteric Ischemia in the Endovascular Era. Essentially, it takes in account all these papers which came out during the years. You see 2019, 2014, 2015, and this is the final table, and it shows that endo versus open, of course, is as if not, I wouldn't present, but it's convenient. It diminishes the length of stay, diminishes the bowel resection and short bowel syndrome, diminishes the need of laparotomy, of TPN and transfusions. And essentially, if you even look at the mortality in all the studies which came out comparing the two different approaches, endovascular was always better, also in terms of mortality. You can see here, for example, a case from our hospital, which I managed with Mr. Watfa. Essentially, you can see here this bowel. It's not very happy, it's not very much enhancing as the other one, so it means like it's early stage of bowel ischemia. You don't see air into the walls, that means it's not very advanced. And so we did a CT angio, and CT angio shows that there's some blockage here, some thrombus into the main branch of the superior mesenteric artery, bringing flow to the ileum. And you can see here, as the CT shows, there's a blockage at the level of the superior mesenteric artery, which is even more evident in the static image. Essentially, what we did go, of course, we crossed the occlusion, which was not very difficult because usually it's fresh thrombus, and we use a device which is called angiojet. So it sprays the RTPA, which is making the blood, of course, thinner and dissolve the clot, and also sucks out the thrombus. You can see the final result is pretty good. So you can see that the bowel is again perfused. You can see from the pre and post how the main branch of the SMA is completely patent. The patient was actually very luckily discharged in a few days with no need for laparotomy, with no need for bowel resection. And that stressed the importance of detecting these kind of things earlier than later. Another big part, and I know that everyone knows about this, is of course, our availability to drain abscesses and collections. So, for example, the cholecystostomy in unstable patients who need some sort of decompression of the gallbladder, or the gallbladder which is, of course, leaking. You can go through the parenchyma, which is an approach which I like a lot, because if you go through a short track of parenchyma, this will allow you to prevent any kind of leak at the moment of removing the drainage. You can see here how the drainage is inserted through the small liver parenchyma tract, or you can go definitely without going through the liver parenchyma. You can see here this approach, which personally I don't like, but there's no literature indication that it's definitely worse. But you can see how you can easily go, and you can prevent maybe a little bit of risk of bleeding, despite if you go for a short and distal parenchyma tract, the risk is minimal. Nephrostomy is another important topic, for patients who have, of course, an obstructed collected system. You see how dilated it is, how septic the patient was. It's very important to go through the lower calyx just to avoid bleeding. This is a Brodell's line, so where the kidney is less vascularized. There's abdominal collections. You can drain under ultrasound guidance, as we said, and you can see the double barrel sign with the drainage inside the collection, or you can drain it under CT guidance. And remember always, especially in this kind of bowel perforations, always position drainage which is big, more than 14 French. Don't be shy. Sometimes I see people putting 6.5, 8 French drainages. It doesn't make sense in very thick collections. Big chapter is pancreatitis. Pancreatitis can be managed conservatively, especially in unstable patients, by drainages. And it's very important, like in this case, to put 2 drainages. One, of course, to flush, and the other one, big one, 20, 24 French drainage, like a surgical one, to drain out all the content. Biliary sepsis is another very important field for us where to use our skills. You can see this dilatation of the intrahepatic common bile duct, and you can see here how the drainage position inside the duodenum can drain out all the infected bile, especially in patients who are very much not fit for any kind of endoscopy or operation. The last but not least is the colonic stent. We don't perform it in my center, but I have good friends who are doing it, especially in this kind of COVID era. Is very important to perform these procedures. You can see how if you put a stent at the level of the obstruction of the bowel, the patient, of course, which is like quite terminal, it doesn't have a very long effect, but can be relieved from the obstruction. And so my conclusion is, before rushing the patient towards the theater, always remember that there's someone who can operate without a scalpel. It is not a joke. This is a proper series you can watch on Amazon.com, and it talks about IRs. And essentially, I want to ask you again the question which I made at the beginning: who do you say I am? And I would say that I'm proudly an interventional radiologist, and I'm the Swiss Army knife of the hospital. And with that, I thank you for your attention.
Thank you very much for that very illuminating talk. I don't know whether I'm muted at the moment or not.
We can hear you.
Yes. Okay. I have a number of questions here, mostly for Mr. Abercrombie. But before we do that, I just would like to ask a question of Dr. Petrone, who has shown us some amazing skills in dealing with these abdominal emergencies. But I think what most of us struggle with is the availability in most hospitals of good interventional radiology when it is needed for abdominal emergencies. And obviously, if you are in a big trust and have access to that, that's great. But there are many smaller hospitals which struggle. And as you've rightly said, a good interventional radiologist can prevent a major laparotomy being necessary and recovering the patient. I just wonder if you had any comments about that particular point.
Thank you. That's a very interesting question, and I think it's about training and about dedication. So the problem is that interventional radiology is still part of radiology, which personally I think it's not the best way to go. Essentially, very recently, last year, the BSIR, so British Society of Interventional Radiology, decided with a referendum to start the way to develop like a separate clinical specialty. And I think this is the key point. If you don't have someone who's dedicated to IR, so who's available 24/7, who is used to work with wires and catheters, is not like someone being diagnostic and interventional radiologist. We need more dedicated interventional radiologists. And I hope that, you know, like I was amazed when I was a medical student, more people will start being interested about interventional radiology, which actually is a separate specialty, because it's so various, as you have seen, that you can't match it with just a little bit of diagnostic and whatever. So we need more dedication. Yes, you're right.
Do you think radiologists are being encouraged to become interventional radiologists, or are they preferring to take perhaps the easier option of diagnostic and reporting? I don't want this discussion to go on much longer, but I think it is a real problem for many hospitals.
No, I definitely think, I will answer very shortly. I definitely think you're right. And actually, there's a very nice paper which came out a few years ago, which divides the interventional radiologists in two groups. So there are the surgical radiologists and the radiological surgeons. So the difference is people who started doing radiology because they wanted to be interventional radiologists like me, so who didn't really enjoy so much the diagnostic, and people who instead started radiology with this kind of, without any kind of offense, of course, but this kind of radiology mind setting, who then develop some endovascular or some interventional skills, and then they're still a little bit fascinated and dedicated to this. But I think the main difference is the setting. If you have the surgical setting, then you will be a better interventional radiologist, definitely, I think.
Okay, thank you very much.